Dr. Andrea Peterson.
And I'm Dr. Eric Mazer. Today we're going to discuss the link between obesity and diabetes. Our guests are Dr. Neil Flock. He's the Director of Bariatric Surgery at Norwalk Hospital, and Dr. Abe Friedman. He's a bariatric surgeon. Both of these doctors are with Fairfield County Bariatrics and Surgical Specialists.
Welcome. Welcome back. Abe,
you.
welcome. Thanks so much for joining us today.
So today we're going to talk about bariatric surgery and its use for weight loss, but it's really, we've learned it's more than that. It's not just simply losing weight. This surgery has profound effects on the body's entire metabolism, doesn't it? So maybe you can tell us a little bit about that and which surgeries go with the metabolic changes. Let's start with you, Neil. I know you're both experts in this.
Well, what we found is after these surgeries were performed, they had profound effects on people's medical problems. And the thinking in the past was both gastric bypass surgery, which was the initial operation performed, would get rid of people's diabetes. We didn't know why. And their hypertension began to get better. And their cholesterol normalized. And all of these discoveries have led to new research in the development and the development of metabolic surgery. And what that means is that these surgeries cure metabolic diseases that I've mentioned. And it includes both the gastric bypass and a newly developed operation or a newly established operation called the sleeve gastrectomy.
And so we're going to get into both of those operations a little bit later in the show.
Maybe before we do, Abe, it must be such an exciting time to be a surgeon. You know, you're helping people in such profound ways, not only helping them lose weight, but really helping major metabolic and major medical problems.
It definitely is, and that was part of the reason why I went into this specialty, was because you have a patient that comes to you, they're obviously overweight, but they have diabetes, they have high blood pressure, they have high cholesterol, sleep apnea, a number of medical problems. And then you tell them, I'm going to do the surgery and it's going to get better. And they look at you, they're like, you're crazy, it's not going to get better. I'm just going to lose the weight, I want to lose the weight. And then they have the surgery, and literally some patients, before they even leave the hospital, they're off their high blood pressure medication, the diabetic medications, and they're telling you, I can't believe it. They come see you.
You just said something very important there. You said before they lose the weight, which is really, to me as an internist, as somebody who is used to dealing with medicines to treat diseases, the thought that somehow this surgical anatomic rearrangement fixes these disorders before the patients lose the weight. Do we understand that at all?
Well, we do have some evidence that it's more than just the weight loss. It is a metabolic component to the surgery, so it affects your endocrine system or your hormones that are sent to different parts of the body, and they send out signals and tell you to do certain things. So these surgeries affect these hormones. So it's not just the weight loss alone, but it's actually something more, something part of your body's composition of, sensors going here to there that's affected and changed after you have the surgery.
Now, Neil, that's so interesting, right? Because a lot of our viewers will know something about hormones. You think about the thyroid and thyroid hormone. A lot of people know about that, or they think about hormones that affect pregnancy and menopause and things like that. But tell us a little bit more about hormones and eating.
Well, it's very simple and very complex at the same time. And a lot of what has happened is that we've discovered that these surgeries work, but how do they work? So all the major research going on right now with mice, unfortunately we have to use mice to help us, but what we've discovered is there are different parts of the stomach that send different signals. For instance, what we call the lesser curve of the stomach, that part of the inner part of the banana of the stomach, that part does not have as much ability to send signals as the outer part, or what we call the fundus of the stomach. We know that the fundus of the stomach has something to do with the signals that are sent from the stomach to the brain to tell us we're hungry, we're not hungry, make our blood sugar go up, make it go down, help us with our hypertension. So what we are now finding out from all these studies being done is that there's certain hormones, and we have some names for them. One of them, for instance, is ghrelin.
Yeah, I think people have heard about that. That's made it into the lay press.
Right. That's the one spelled Ghrelin.
It kind of sounds, I think of gremlin every time I see it. But we know that, for instance, normally, after we eat, our ghrelin level is very low. And then right before dinner, we're getting hungry, our ghrelin level climbs way up high, and after we eat, it comes down again. And before lunch, it starts to creep up, and after we eat, it goes way down again. Well, after these surgeries that we're going to talk about today, Dr. Friedman and I, believe it or not, your ghrelin stays down here before dinner, before lunch, after lunch, and it does not go up. So it's amazing what we are now discovering, and we only know of a few of them in comparison, but we know that there are many more of these hormones. So we don't know exactly what they do, but we know that they solve the problem.
I think one of the things that was most amazing to me, and I asked Abe to comment on it, was that the articles that appeared several years ago now in the New England Journal, when they actually looked at morbidly obese patients who had weight loss surgery versus those who didn't, and they actually lived longer. I mean, you actually were improving not only cosmetics and not only minor aspects of disease, but it was actually something where people survived. It cured diabetes, it cured hypertension, and people lived longer. We never thought of these disorders as surgical diseases, and all of a sudden there were surgical cures, so we've typically thought of as metabolic or medical diseases.
Right. That study.
I'm sorry, I've talked too much, but I'm just so fascinated
okay.
by it. It's
But
amazing.
in that study, they looked at the mortality or the risk of death, as your weight goes up, and once your BMI or the body mass index, that's your height over the weight, above 40, dramatically goes up your risk of death. And once you lose the weight, or you have the weight loss surgery, that risk of death definitely drastically drops. And it's not only the risk of death, it's also the quality of life. They looked at patients' quality of life after surgery, and 95% or more said they had an improved quality of life. And so they live longer, they're happier, they're healthier, so it's an overall improvement in their life and anything they want to do.
Also in that study, that study looked at patients going out 16 years in Sweden, and it showed that at 16 years there was a 50% survival advantage for patients who had gastric bypass surgery and something called vertical banded gastroplasty. So the survival advantage was dramatic.
Yeah.
And when they looked at what people died from, people died who didn't have the surgery. There were twice as many cancers in the patients who did not have surgery compared to the patients who did have surgery. And there were twice as many heart attacks as well. So there was a dramatic advantage. And patients sometimes fear this surgery. They're scared. Geez, if I have surgery, I could die from it. And in fact, the survival, the risk of dying from surgery is extremely low. It's 0.13%. And I'm not sure that you know what the survival or the risk of dying from gallbladder surgery is. It's actually 3 times higher. It's 0.52%.
And by the way, that's all less than 1 in 100, just for people that are not good in math. We're really talking about 1 in 1,000, a little bit over 1 in 1,000.
So the survival is amazing, the survival advantage for these types of surgeries.
So we want to talk a little bit about, well, before we even go into this, who should be thinking about this? Because I know the indications for surgery have been expanding. Both age-wise, I guess, weight's been lowered and age has been expanded. So who are the people who should be considering seeing a bariatric surgeon for weight loss reduction and metabolic surgery?
Well, in 1991, the National Institute of Health gave guidelines as to who's eligible for surgery. And they said that anyone with a BMI of 35 or higher is eligible for surgery if they have a comorbidity. Now, comorbidity is either high blood pressure, diabetes, cholesterol, sleep apnea, a number of things. Or if your BMI is greater than 40, then just that BMI alone qualifies you for surgery. Now, there has been recent research about if your BMI is 30 to 35, and the insurances don't cover it, but it seems to be helpful as well. But we still don't know a lot about that part. But mainly it's patients BMI greater than 35 with a comorbidity or a BMI greater than 40.
How about teenagers or young adults who are massively obese?
Those patients are also considered for surgery as well. And many programs will take on patients 18 and above. There are certain situations where patients who are 14 years old and above can be operated on as well. And I think the movement is to help adolescents at a younger age.
And we'll talk a little bit more about some of the specific surgeries, but I know when we've talked about some of these techniques in the past, one of the things that's really important to you, Neil, I think, is to let our viewers know this is one component of a whole system for helping people lose weight, isn't it?
Absolutely. When you're talking about losing weight or even treating these medical problems, it takes everybody involved. It's comprehensive. It's the surgeon, yes. It's the patient as well. And it's the patient seeing nutritionists, therapists, the patient exercising, following the diet, and trying to work with the surgery that's been done. So all those things are imperative to success. And it's important to get the patients on board in the beginning and to understand that all this is necessary to be successful. And we do that by educating our patients. We bring them to a seminar, have them meet with a nutritionist, have them meet with a therapist, and work on a program.
It really takes a team.
It takes a team.
And it takes a lifetime of commitment.
So Abe, we have a video that we're going to bring up pretty quickly here to maybe have our viewers learn a little bit about some of the specifics of one of the particular kinds of weight loss surgeries, and maybe you can start telling us about it.
And we thought we'd start with the gastric sleeve
Correct.
bypass because
Correct.
it's simpler, so for people to
Right.
understand. So let's bring up the video so we can look at that and talk about. Here we are.
So the laparoscopic sleeve gastrectomy, it's a laparoscopic procedure, so no big incisions. You have small cuts. Those are the ports that we use. And then we put an instrument through them to manipulate things on the inside.
Now we're into the inside. Here.
Right, now we're inside and you have the esophagus, and that's your stomach. Now your stomach normally holds about 1.5 liters to 2 liters of fluid. So if you think about like a 2-liter bottle of soda. And that's where the juice is going in.
This is sort of a normal flow that we're seeing here.
And it goes
But,
in the stomach, and you can see how much is in the stomach, so it takes a lot for you to get full.
by the way, just to remind our viewers, the esophagus attaches to the mouth, so that's where the food
Right.
goes down.
When we do the sleeve, we staple that big part of the stomach, so you're left with just a tube. And that tube now holds only 100 milliliters of fluid. So
And that
it's
thing
about
on the
a
right you take out and throw away,
Right.
or send to the pathology
Right, the
laboratory.
transected part we take out and we can't put it back in. So now the food that goes in there, there's only so much less food that could fit there, so you get hungry quicker. And the food takes a lot longer to go down, so
You get
feel
hungry quicker or full quicker?
full quicker.
Yeah.
Sorry, that's my mistake. And your satiety is there, so you feel comfortable with all the...
And you've also taken that part of the stomach out that produces the ghrelin that we talked about
Right,
before.
so that part of the stomach and the upper part, it's called the fundus of the stomach, has a lot of ghrelin-producing cells. People have looked at it under the microscope and they found a lot of cells there. So when you take it out, your ghrelin level goes down. So as Dr. Flock said previously, the level always stays low. So you don't have the appetite that you had before.
So it's not just simply you can't fit as much food, your appetite is actually lower as well.
That's correct.